So we go to the next talk. That will be by Dr. Sandeep Mandal. He's going to speak on the first 5 golden years, where probably that is the way of roadmap to prevent the CKM collapse. So Dr. Sandeep Mandal, can we have his CV slides? Don't have slides. Okay. He's a known practitioner in the city of Kolkata. He's a DRW member since almost since inception, and he contributes academically in almost all the meetings. Thank you, Dr. Sandeep. You can go ahead.
So thank you, the organizer, and thank you, Dr. Vijay Patni, for giving me a chance to interact with the learned audience. So today my subject of discussion is CKM, that is cardiovascular kidney metabolic syndrome. Is it a new syndrome? Not really. The conception was in the past, but it was actually formalized of what we have learned over the years. So the cardiovascular kidney metabolic health, this is the presidential advisory from the American Heart Association. It was published in 2023 in the October issues. It defines CKM as a syndrome, a systemic disorder which is characterized by pathophysiologic interactions among various metabolic risk factors, chronic kidney disease and cardiovascular system, leading to multi-organ dysfunctions and a high rate of adverse cardiovascular morbidity and mortality. We know that there is significant overlap between the obesity, type 2 diabetes, chronic kidney disease and heart disease. So what is the staging of this CKM? We know that CKM syndrome is a progressive condition. It commonly begins in the early life, and with the biological, social and environmental exposure of the subject, it leads to accumulation of excess and dysfunctional adipose tissue. What is meant by that, we may discuss it later, and development of insulin resistance. Excess adipose tissue is the key pathogenic factor of the CKM, which progress to the development of metabolic risk factors. These include the hypertension, hypertriglyceridemia, metabolic syndrome, type 2 diabetes, and chronic kidney disease. And over the time, these metabolic risk factors, they fight among or themselves and ultimately leads to development of subclinical coronary atherosclerosis, which is determined by the coronary calcium calcifications and progressive declinations of the renal functions. So these are the stages of the cardiovascular kidney metabolic syndrome. We have the stage 0, that means when there is absolute absence of the risk factor, no diabetes, no hypertension, normal lipids, and if you consider the intervention, this is the best time to interventions. That is the primordial preventions when there is absence of the risk factors. The stage 1 includes the excess or dysfunctional adipose tissue, and in this stage you may get overweight or obesity, impaired glucose tolerance. With subsequent progression of the disease, we get a stage of stage 2, which is the metabolic risk factors and CKD. And in this stage, one may get hypertension, hypertriglyceridemia, frank type 2 diabetes, and metabolic syndrome. With further progressions, we get stage 3 disease, which is the subclinical cardiovascular disease in CKM syndrome. So in this stage, we may get either the subclinical ASCVD, which can be determined by coronary artery calcifications, calcium scoring, or we may get a stage of the subclinical heart failure, which can be determined by the NT-proBNP, the HS troponin level, or by echocardiography. And ultimately, with lack of treatment, ultimately we develop the stage 4 disease, that is the clinical CVD in the CKM syndrome, and all form of the cardiovascular disease, atherosclerotic cardiovascular disease or heart failure develops here. We may get peripheral arterial disease, stroke, atrial fibrillations, and other conduction abnormalities. So what is the rationale of staging? As we know that CKM is a progressive disease, so importance of early detections of under recognized clinical condition is needed. Each stage represent a higher level of absolute clinical risk. Our principal focus is to reduce the chance of the cardiovascular complications with additional focus on to reduce the kidney failure. Coming to the screening of the CKM syndrome, well, it should be started in very early age group, that is less than 20, if we consider the less than 21 years of the age group. Annual screening for overweight and obesity using sex and age specific CDC growth chart. Very importantly, mental and behavioral health screening. Blood pressure should be checked annually as early as each visit at the age of 3, and fasting lipid profile at the age of 9 to 11 and again at 17 to 21. If there is positive family history of hypertriglyceridemia, that it should be screened at as early as age 2, and screen for the glucose intolerance and monitor should be for ALT should be done. Regarding the screening more than 21 years, BMI and waist circumference annually, blood pressure, A1C, lipid panel at stage determined intervals, microalbumin and creatinine measurement at stage determined interval, and screening for the fatty liver disease as directed by the guidelines, and of course coronary arterial calcification at specific cases. Screening for the CKM syndrome also includes the social determinants of health that screen for the financial strain, mental health, and education or literacy. I think all of us are aware about these slides. Here the CKD is classified according to the albuminuria and the EGFR. We know that any degree of microalbuminuria or macroalbuminuria, or if the EGFR is less than 60 and persists for more than 3 months, then it is defined as CKD. And higher the proteinuria and lesser is the EGFR, more is the chance of the cardiovascular disease and CKD mortality. Coming to what are the management protocol. As I have told you that best time to manage at the disease at stage 0 when there is absence of any risk factors. So eat healthy, be physically active, don't smoke, get quality sleep, already mentioned by Dr. Patni. Keep a healthy weight, manage cholesterol level, manage blood sugar, manage blood pressure. If you miss the train here, target in the next stage. So stage 1 is the exceptional obesity or excess fat. So comprehensive lifestyle interventions, weight loss counseling. We know that 5 to 10% of the weight loss is associated with improved BP, glycemia, and lipids. And if there is more than 10% of the weight loss, it is also associated with lower cardiovascular events, as has been shown in various trials. And the increasing trials which is associated with more than 15%, 20, 25% of the weight loss has actually changed our way of management. And bariatric surgery is associated with more than 20% of the weight loss, and it is also beneficial for the reductions of the cardiovascular and the CKM mortality. Management of stage 2 disease for hypertension, target blood pressure is less than 130/80, or for a diabetic in such particular subjects less than 120/80. ACE inhibitor and ARB is preferred if there is presence of albuminuria or the CKD. For hypertriglyceridemia, initial lifestyle changes, screen for the thyroid disorder. Diabetes, we know that moderate to high intensity statin actually reduces the chances of the atherosclerotic cardiovascular disease. But for patient with diabetes plus very high cardiovascular ASCVD risk factors, we may need to add ezetimibe for further reductions of the LDL cholesterol. SGLT2 inhibitor has been shown its salutary effects for reductions of the heart failure, MACE, CVD, and also the renal benefits. GLP receptor agonist is associated with reductions of the body weight, improvement of glycemia, and also MACE and CVD reductions of the mortality. Metformin can be added with the SGLT2 inhibitor if we fail to achieve our glycemic target. For CKD, AC inhibitor or ARB is preferred for albuminuria and better blood pressure control. Of course, it reduces the chances of the progression of the CKD as well as reductions of the CVD complications. SGLT2 inhibitor should be used if the eGFR is more than 20, as it reduces the chances of the renal disease as well as reduce the chances of the heart failure. And in the present day, finerenone has been advocated in cases of the diabetes with eGFR more than 25 to reduce the adverse kidney and CVD events, particularly after the evidence of the confidence trial. For management of the stage 3 subclinical heart failure, it can be determined by NT-proBNP or HS troponin or by the echocardiography, and the pillars are AC inhibitor, and beta blocker is also essential, particularly if there is asymptomatic left ventricular dysfunctions. AC inhibitor and beta blocker are recommended for as a guideline for subclinical heart failure. For in patients of type 2 diabetes, SGLT2 inhibitor has also been shown to reduce the heart failure hospitalizations and reductions of the cardiovascular mortality. For atherosclerotic cardiovascular disease, the calcium artery calcium scoring is coronary artery calcium scoring is essential. For CAC 0, where the 10 years ACVD rates is less than 5%, statin is recommended. But if the CAC score is more than 100, then it is associated with increased chance of the ACVD risk, and in that case you may need to add aspirin plus PCSK9 or the GLP receptor agonist to reduce the chance of the cardiovascular mortality. And finally, coming to the stage 4, for the heart failure with reduced ejection fraction, we know the 4 pillars of the therapy: ACE inhibitor, ARB, the sacubitril valsartan, the beta blocker, MRA, and the SGLT2 inhibitor. And for the obesity, metabolic syndrome and CVD, the GLP receptor agonist or the 2-incretin, that is the combined GLP and GIP receptor agonist, it reduces the weight loss, as well as some of them has shown improved cardiovascular morbidity and mortality. Bariatric surgery, of course, is associated with more than 20% of the weight loss and has been shown to improve the ASCVD risk factors. Last slide. For diabetes mellitus and ASCVD, GLP receptor agonist and SGLT2 inhibitor has been shown to reduce the chances of the cardiovascular mortality, and for heart failure, SGLT2 inhibitor is the principal therapy. Of course, one should use the thiazolidinase. So this is the patient-centric implementation of the CKM, consideration of the SDOH, access to pharmacotherapies, addressing the research gap, CKM educations, enhance obesity management, and also supporting health lifestyle in communities. So I can conclude by saying that CKM syndrome is a lifelong progressive syndrome affecting nearly every organ system of our body. And our motto is to detect the syndrome early. So early prevention, interdisciplinary care is the principle of the target, and measurement of urine, albumin, creatinine ratio in addition to estimated GFR in those for the CKD, diabetes, hypertension, and metabolic syndrome. Thank you for your patient hearing.
Thank you, Dr. Sandeep Mandal, taking us to the CKM